So now let's see the scoring system used to assess the stroke risk in AF patients. So that's the CHAD-VAS score. Here you see the C, that stands for congestive heart failure. H stands for hypertension. A stands for age, more than 75 years. D stands for diabetes. S stands for stroke, that is by a stroke. TIA or venous thromboembolism. V stands for vascular disease. A stands for 65 to 74 years old. C, we can take that as sex, and that stands for female. Here females have a score of 2. So congestive heart failure has a score of 1, hypertension 1, age more than 75 has a score of 2, diabetes 1, stroke, prior TIA or venous thromboembolism has a score of 2, vascular disease 1, age 65 to 74 1, then female sex, that's not 2, it's 1. So here the only 2 factors that has a score of 2 will be your age more than 75 years and prior stroke, TIA or venous thromboembolism. Now let's look at Has-Blood score. That is the risk of bleed. So why do you use the CHAD-VAS score? It is used to assess the risk of stroke, and by the use of CHAD-VAS score you can predict whether they'll have a low, intermediate or moderate and a high risk of stroke. So if your patient has a score of 0, that means low risk of stroke. If your patient has a score of 1, moderate risk of stroke, and if your patient has a score of 2, that's high risk of stroke. So it is advisable, it is indicated to anticoagulative patient if he has a score of more than or equal to 2 for males and more than or equal to 3 for females. Why females 3 is that females will get a score of 1, minimum 1, just because that patient is a female. So now we go to Has-Blood score. Has-Blood score is used to identify the risk of bleed. So H here stands for hypertension, A stands for abnormal or altered liver or renal parameters, S stands for stroke, B stands for prior bleeding, L stands for labile INR, E stands for elderly, that is more than 75 years of age, more than 65 years of age, and D stands for any drugs that is going to alter or alcohol. So that is 1 point for drug and 1 point for alcohol. So here each of your factor will be getting one for abnormal liver, one for abnormal renal parameters, one for history of stroke, one for bleed, one for labile INR, and one for elderly. And here again 1 point for each. So here again, if your patient has a score of 1, that's a low risk of bleed. If your patient has a score of 2, that's intermediate or moderate risk. If your patient has a score of 3, that is high risk. So now let's look into the various options that are available as drugs for reducing the risk of stroke. So you have two drugs, where you have vitamin K antagonist and your NOAC. So vitamin K antagonist, you have warfarin and NOACs. The different NOACs, you have apixaban, rivaroxaban, dabigatran, and edoxaban. So what is the difference between these two? So if you look at vitamin K antagonists, your onset of action will be slow for your warfarin, it will be rapid for your NOACs, and dosing, so variable dosing for vitamin K antagonists. Here it's fixed dose. And is there any is there any interfering effect with food? Yes, for warfarin. No for NOAC. Any drug interaction? Many for warfarin and a few for NOACs. Do you need routine lab monitoring for your vitamin K antagonist? No. Yes. You need to check your INRs regularly. Yes. In case of a NOAC, no. So your half-life, your warfarin has higher half-life and your long half-life, and your NOACs have a short half-life. So what is the absolute contraindication for your anticoagulation? So any active major bleeding, severe anemia, and recent intracranial bleed, and platelet and a platelet count of less than 50,000. So all these will be your absolute contraindication for anticoagulation. Do antiplatelets have a role in stroke reduction? So let's look at single antiplatelets and dual antiplatelets. Single antiplatelets, no protective role. Increased risk of ischemic stroke. And what about the dual antiplatelets? Your dual antiplatelets have an increased risk of bleed. So even so, no role for single antiplatelets, no role for dual antiplatelets. Now let's go into management of atrial fibrillation. So a management of atrial fibrillation will depend on whether it is an acute or hemodynamically unstable patient, or if it is a hemodynamically stable patient. So if you have a hemodynamically unstable patient with acute pulmonary edema, shock, or acute ischemia, then what do you do is you go for DC cardioversion, synchronized DC cardioversion. And you can try a shot of ibutylide. Now, what if it is a hemodynamically stable patient? Then you can go in for strategies like rate control, anticoagulation, and rhythm control. So perform rhythm control based on the duration of your AF. So if your AF is more than 48 hours, there's a high risk that the patient will have a thrombus. So anticoagulate and defer cardioversion by 4 weeks. So what if a patient has an AF for less than 48 hours? Then you can go in for rhythm control strategies. A patient with an AF of more than 48 hours, but you need to perform an immediate cardioversion. Then what you should do? You should rule out the possibility of a trans-ESO. You should rule out the possibility of a thrombus by trans-esophageal echo. Then anticoagulate for 4 weeks. So if your patient develops an AF and the duration is less than 48 hours, then you can go in for rhythm control in the absence of mitral stenosis, hypertrophic obstructive cardiomyopathy, left atrial enlargement, and a past history of embolic events. So in the absence of mitral stenosis, hypertrophic obstructive cardiomyopathy, left atrial enlargement, and past history of embolic events, you can go in for rhythm control. So your rhythm control will fail in the case of left atrial enlargement because that will act as a foci for future AF.